asked to speak on open prostatectomy, a procedure which is considered invasive and not discussed in this era of endourology and lasers. I will speak on it, restricting my discussion on open prostatectomy for a gland size more than 150 cc with available evidences. Now, this is EUA guidelines 2020, which has a strong level 1 evidence for open prostatectomy. Next slide, please. Another guideline which equates open prostatectomy to all other endourological procedures for substantially enlarged prostate with moderate to severe LUTs, and this is level 1 evidence. This is a recent meta-analysis of randomized controlled trials where the resection, where the enucleation done by any means is better than resection at most of the parameters, and this has been supported by many speakers, Dr. Mallikarjun sir also. Yes. The medical treatment has brought 2 changes. One, now the rate of surgery has decreased, but more and more patients are coming at an older age with larger glands. Now, I have considered the topic for only glands more than 150 cc. The options are HOLEP, bipolar enucleation, bipolar TURP, and open and simple prostatectomy by any means. Now the question is that how many have access to open? How many can complete this procedure of gland more than 150 cc? Will it be a single stage or in 2 stages? Morcellation is done in the same sitting or next. What will be the time taken? At least 2 to 3 hours. And what will be the effect of 2 to 3 hours of resection with 20 French sheaths on urethra? And what if the morcellator goes out of order? I'm not talking of the consultants who have just presented their work because they have mastered their techniques over decades. I'm talking of the fresh postgraduates or having few years experience. If they have to deal with 150 cc gland, what would be their choice? Now, simple prostatectomy, 150 gram, because up to 120, 125 grams, bipolar enucleation can also be done. Same time, there is no size limitation for simple prostatectomy. Any size above 150 gram will also do. Same time, we can deal with bladder stone, diverticulum, and very important, we often forget what is the state of urethra before considering any long endourological procedure, because the long procedures, their duration is directly related to stricture urethra. This is our departmental data. Last year, 4,534 surgeries done. Out of this, 317 for BPH, 9.4% were open surgeries, 9 for prostates more than 150 gram, and 20 for prostates with associated conditions like large vesical calculus, stricture, narrow urethra, or diverticulum. The advantages of open enucleation are complete enucleation, least urethral morbidity, short learning curve, 5 to 10 cases, quick surgery, and it is least expensive. These are 2 specimens of more than 150 grams. This procedure can be done in less than 1 hour. Now, any disadvantage of transurethral surgery is that you need to have surgical expertise, you need to have equipment. Many times you have to stage the procedure because the gland size is more, or there is associated bladder stone. The biggest problem of long transurethral surgeries is, if you follow them, the incidence of alarming urethral stricture, not only stricture, their complexity also. Most of these procedures, they require time. So ergonomically, you can do only one procedure in a day. And if not done properly, if left out, tissue will have high recurrence rate. Now, question is that 150-gram gland, how many surgeries MCH gets during training? How many fresh PGs are competent at resecting 100 gram in one stage? And if they are not able to deal with 150 gram, how many of them will refer to the proper place? So this is an article, a recent article in World Journal of Urology 2019 by Dr. Sanjay Kulkarni, rating the stricture rate after TURP from 2.2 to 9.8. If you consider the stricture rate of open prostatectomy, the literature is very sparse, and I could find only 2 articles where the rate has been less than 1%. This is the same article quoted by Jian Val Wang, where Dr. Kulkarni has done surgery on 170 patients of post-PRP stricture. In that, more than 11% were pan-urethral with the stricture length more than 16 centimeter, requiring perineal urethrostomy. And rest of the cases, the average length of graft for only required was more than 6 centimeter. So these are 2 cases with post-transurethral surgery, pan-urethral strictures, who ultimately required perineal urethrostomy. So this is one 66-year male who underwent TURP by a very senior urologist, and he came back 3 weeks later with penile gangrene resulting into autoamputation. This is terrible, horrifying, unheard complication. Probably the regions are narrow urethra or previous stricture, and patient did not come early, probably wouldn't have resulted into this terrible complication. So it is very important to assess urethra before contemplating a 3 to 4 hour surgery. And if I compare the open prostatectomy, a broad procured scar healed by sucking intention, I feel is better than even a small scar in urethra. What about device malformation? This is a recent article published in 2019, which is showing morcellator dysfunction up to more than 50%. So how many of us have a morcellator in reserve which costs lakhs of rupees? And what if morcellator is not there? I have heard many people, experts, not hesitating to give a pharyngeal incision to deliver the prostate after 3 hours long HOLEP. But this is still considered minimally invasive than open prostatectomy. If you see the ergonomics, the 3 hour surgery is associated with a lot of musculoskeletal pains and aches. You can't perform more than 1 surgery in a day. As previously pointed out by many speakers, if you compare the TURP with the transvaginal prostatectomy, apart from IPSS and Qmax, which are significant, if you see the amount of resected tissue is just 60% of what is there in open prostatectomy. Therefore, resulting into high re-TURP rates. This is a large cohort of more than 20,000 patients At 80 years, the redo surgery rate was 8.3%. So the only disadvantages are it is considered invasive, 5 to 6 centimeter abdominal scar, longer catheterization. We have reduced urethral morbidity by keeping 22 French catheter for 2 days, followed by 16 French catheter for 5 days. Bit longer hospital stay and possibility of wound infection. Now, the biggest gland I enucleated was 450 cc. Now, you can see that in the circle, this was the intraprostatic part, and most of the gland, that 70% of the gland was intravesical. Now, the simple prostatectomy, larger the gland, easier the enucleation. The size does not change the duration of the procedure. 66 centimeter fenestrial incision, no blood transfusion, operative time 55 minutes, no post-op incontinence. If you compare the cost, it is just 3,000 rupees, and this procedure was done free under government sponsored scheme with excellent patient and surgeon satisfaction. But the irony of this procedure is, despite strong evidence by EUA, this is considered obsolete because this is less appealing to patients and urologists, less lucrative as compared to other procedures, and if the same way continues, this art will be lost. So I conclude that simple prostatectomy is the standard of care in gland size more than 150 cc. If you have robot, fine. If you don't, no problem. It is equivalent to other endourological procedures. It deals with bladder and prostate problems in one stage. Least recurrence and least stricture rate can be performed at a remote place with simple setup, and I believe it should be retained in the core curriculum of urological training because there is level 1 evidence in EUA 2020. I have trained all my residents working with me, and I feel that those in the initial career, if they find bigger prostate and if they feel that they can't do it in one stage, they should not hesitate to do it by simple prostatectomy. Thank you.